Today we are going to discuss the NEET PG 2020 recall questions, right? So starting off with the first question, that is about the NO synthesis, right? So answer of this question is option D, L-arginine. The answer is L-arginine. Now let's see how this synthesis occur and some few important points regarding the NO, right? So NO is also known as the nitric oxide, is also known as ETRF, right? Endothelium derived relaxing factor. Now, in the name itself, it is saying that it is a relaxing factors. That means it is causing the relaxation of smooth muscle inside the vessels. That's why it is causing the vasodilation, right? So, in the coronary artery, mainly the effect is in the coronary artery. So, it is causing coronary artery dilatation. And it also supports the endothelial repair. Right? So it is doing two works, that is the artery dilatation and endothelial repair. And that's why if it is causing this, so the effect will be increased blood flow and about the BP, decrease in the BP. So significance is mainly during the exercise, as well as some of the drugs uses its mechanism, that is sildenafil, right? So that drug uses the NO pathway, right? Nitric oxide pathway is used by drugs like sildenafil. Now, and this is in one of the exams, it is asked that either it is autocrine, paracrine or endocrine. Remember, this signaling molecule is autocrine as well as paracrine. It is also autocrine as well as the paracrine signaling molecule. Right? So, this is about the NO. Now, if we have to see how the NO is synthesized, we do have a diagram for it. Let's have a look on that. So, this is the nitric oxide signaling pathway. Now, over here we can see that if the nerve is stimulated, that will release the neurotransmitter. Over here it is the acetylcholine on the terminals. Now, that will bind to the endothelial cells, right? Once the signaling molecule is bind to the receptor, what happens in the smooth muscle is the L-arginine will be converted into nitric oxide with the help of enzyme which is known as nitric oxide synthase, right? And now, once it is formed, it will be diffuses across the membrane, and that causes the conversion of GTP into cyclic GMP, which is the second messenger, right? And it will go to the smooth muscle cells. Remember, this is forming into endothelial cells and it is going to the smooth muscle cells. Smooth muscles will be relaxed, right? Then the smooth muscles will be relaxed. Okay, so this is about the nitric oxide and its pathway. So going to the next question, question number 2, right? Question number 2 is about the clotting factor and the patient is on the warfarin. So what will happen? So answer of this question is option A, factor 2. Now let's see how this answer is correct and how, from where it came. Okay, so let's discuss the question number 2. Remember, the warfarin, the drug warfarin, it is the antagonist. It is the antagonist of vitamin K. Now, what is the role of vitamin K in the clotting pathway, right? This is the necessary element. Vitamin K is a necessary element for the clotting factors 2, 7, 9 and 10. 2, 7, 9 and 10. What happens is, as well as, and the naturally occurring endogenous, that is endogenous anticoagulants. Those are the protein C and protein S. Right. So, what the vitamin K causes is, it causes the gamma carboxylation of those 2, 7, 9, 10 clotting factors, right? That means they make it active. The clotting factors are present in the inactivated form in the blood, but this vitamin K makes them active, right, via the gamma carboxylation. When we give the warfarin, what happens? The synthesis of vitamin K, it decrease in the synthesis. It causes decrease in the synthesis. The warfarin decreases the synthesis of vitamin K. In turns, the gamma carboxylation of factor 2, 7, 9, 10 will be decreased too. So, that's why there will be no activation of these factors, right? So, it decreases the gamma carboxylation of factor 2, 7, 9, 10. So, answer over here will be option A. Okay, moving to the next question. Identify the sleep waves marks in the ECG during the sleep wake cycle, right? And they're asking about the first wave. Now, this is the mixed beta wave. Mixed beta wave. Now, the answer of this question is option D, REM sleep, right? It is the option D, REM sleep. Now, let's discuss quickly about some of the EEG waves, right? Now, EEG means electroencephalography, through which we can study the brain activity during the awake state as well as the during sleep, right? And they do have a different hallmarks for different stages, so that we can know if the patient is in the particular sleep stages, right? So, for that, we divide the sleep into two phases, that is REM and NREM, right? NREM is further divided into again 4 stages, that is 1, 2, 3 and 4. NREM 1, NREM 2, NREM 3 and NREM 4. Let's talk about one by one and their waves, right? So, NREM, that is non-rapid eye movement sleep. So, starting off with the first stage, right? The whole sleep cycle, the one sleep cycle will be of 90 minutes duration. 90 minutes duration. In NREM 1, what happens is, in the EEG, you will see the mixed alpha and theta waves. Alpha and theta waves in the EEG. The person will be in the light sleep, right? He will feel drowsy and he will be somewhat in the awake state, not in the deep sleep. So, that's why it is known as the stage of light sleep, right? Moving on to the NREM stage 2. What happens in the NREM stage 2 is, you can see the EEG waves, that is the theta waves, right? In stage 2, what happens is, you can see the theta waves. But over here, there is a hallmark of this stage. Hallmark, there's a hallmark of this stage is, what happens is, there is you can see the sleep spindles as well as K complexes. Sleep spindle and K complexes, right? So this is the hallmark of this two wave. They are nothing but the burst of particular types of waves. Those are known as sleep spindle. They shape like the spindles, so that's why they are known as like this. And K complexes are somewhat like this. The waves will be like this. So it is like a cursive K, so that's why it is known as K complexes. Moving on to the NREM stage 3, what happens is, over here the delta waves start to appear. In stage C, what happens is delta waves start to appear. I'm saying it is start to appear, not the maximum, right? So over here you can see the theta waves as well as delta waves, but delta waves will start to appear. That was the question of the PGI exam in last year, right? So moving on to the next stage. Now in NREM 4 sleep, it is also known as classical deep sleep. It is also known as classical deep sleep, right? So what happened in the sleep is, why it is known as classical deep sleep? What is a hallmark of this is, there is maximum appearance of delta waves. Delta waves are maximum over here. What do you mean by maximum over here? More than 50% of the waves, you'll see the delta waves. So that's why it is a hallmark D for deep sleep. So remember, if you can see the delta wave on ECG, that means the person is in the deep sleep. So how to remember? D for D, right? Delta wave is seen in the deep sleep, and that's why it is known as classical deep sleep, and that's why it is known as classical deep sleep. So this is about the NREM sleep, right? Moving on to the REM, that is rapid eye movement, right? This is a paradoxical sleep. This is also known as a paradoxical sleep. Why it is known as paradoxical sleep? Because you will see a paradox that a person is in the sleep, but you will see a mixed beta wave. You will see mixed beta wave. Though the person is in the sleep, but you are seeing high mental activity kind of waves. So that's why it is known as paradoxical sleep. I'm repeating that it is a paradox that though the person is in the sleep, but you can see the beta waves in the EEG, and that's why it is known as the paradoxical sleep, right? And in the REM sleep, the person have dreams, and those will be remembered after once he wakes up from the sleep. So the dreams which are come in this stage, it is known as nightmare. Nightmare. And the dreams also come into NREM sleep. Those are known as, if the dreams come in the REM phase, they are known as nightmares, right? And if they come in NREM stage, they are known as night terror. Frightful dreams, but they will not be remembered. So that's the difference. If the examiner asks that the person can have a dream into REM, NREM, both, none, you should go with the both, because in both the type of stages, you'll see the dreams. But in the NREM stage of sleep, the dreams will not be remembered, right? N for N, you'll remember not remember. And in REM sleep, the dreams will be remember. So REM for remember, right? And that's why they are known as the nightmares. So that is all about the sleep, right? Moving on to the next question. So answer over here of this question will be yes, the option number D. Now moving on to the next question, that is about the yes, the cerebellar cells, right? There are 5 types of cells: basket cells, stellate cells, granular cells, Golgi cells, and Purkinje cells. We do have a diagram for this. Now, first of all, for the answer, this answer over here will be Purkinje cells, right? Purkinje cells. Because you can, as soon as you will see the diagram, you will get to know why the answer is Purkinje cell. This was the diagram for the warfarin test, right? It is inhibiting the activation of the vitamin K from the epoxide to the reduced form, right? So, this cannot be activated and hence the gamma carboxylation is hampered too, right? So, moving on to our question of the Purkinje cells, that this is a diagram of the cerebellar cells, right? And we are going to see how the cells work, right? Because the examiners are fond of asking the question about the cerebellum and cerebellar cells, right? So now let's see. Over here you can see the output as well as inputs, right? So you can see only one cell is having the output, that is the Purkinje cells, right? Only one cells that gives the output from the cerebellum is the Purkinje cells. All other cells are for the inputs of the cerebellum, right? This is the only cell which is giving the output. Talking about the cerebellum, cerebellum act helps in the coordination. Remember, it is not deciding the movement or programming the movement, it is just coordinating the movement. Whatever errors are there, that is removed by the cerebellum. The mechanism we will see, first of all, the functions of cerebellum. Functions of cerebellum. Now, what are the functions? Why it is important to have a cerebellum is, it helps in the coordination of the movement, right? And hence maintaining the posture also, posture maintenance. Coordination of the movement, and hence in turns it is helping us into the posture maintenance also. Then it also helps in motor learning. Motor learning through one of the type of synaptic plasticity, that is LTD, right? Long-term depression, that we'll see in the synaptic plasticity only, right? So just remember for now that it helps in the motor learning also via one of the synaptic plasticity phenomena, that is long-term depression, right? And it also helps in some reflexes, for example, vestibulo ocular reflex, vestibular ocular reflex, which is also known as saccade, right? Which is also known as saccades, right? So that is all about the functions of the cerebellum. Now let's see how these different cells that we can see in the diagram, they work, right? For the functioning of them, we should remember how the stimulus come and how it correct the error, and that's why these all functions are possible. So first of all, if there is suppose any stimulus is given, right, through the afferent, it will go to the cortex. The integrating center is cortex, right? So it will go to the cortex and then it will go to the pyramidal tract. Once the decision is taken by the cortex, it will go to the pyramidal tract. From the pyramidal tract, it will move to the inferior olivary complex. Inferior olivary nucleus. From the inferior olivary nucleus, then it will come to the cerebellum. First of all, it will come to the fibers which are known as climbing fibers. Right, from the inferior olivary nucleus, it will come to the climbing fibers, and from there, it will go to the Purkinje cells. Right. So, this is the one of the easy way to learn that how the movement is taking place, right? How it is coming into the cerebellum and how it is going out. Output is the only one cell, that is a Purkinje cell, which is the biggest cell. You can see over here, which is the biggest cell of the cerebellum, right? So, now the proprioceptive feedback from the muscle are brought by the mossy fibers, and then suppose we have to write that this is the mechanism of action, but what happens is, suppose this is the common pathway, right? One of the copy came to the cerebellum. Now, one more copy should be there from the muscles also, that the muscle is giving the proper coordinated movement or not. For that, what happens is, from the muscles also, proprioceptive feedback coming from the muscles are brought by mossy fibers. Right, from the mossy fibers, for example, suppose I have to do 10 degree of flexion. This is example 10 degree of flexion for 10 seconds. But what happened is, suppose there is a 8 degree of flexion happened, right? So there is a loss of 2 degrees, right? So now the correction is needed. Now what happened is, suppose this was the regular pathway and we said that I had to do 10 degree of flexion for 10 seconds. But what happened is, there is only 8 degree of flexion occurred. Now there is a 2 degree of lag which should be covered up, and how it is covered up? What happened is, once the copy is there in the cerebellum, there is a calculation of error. There is a calculation of error by which cells? Our Purkinje cells. Calculation of error by the Purkinje cells, and thereby they correct the error and give the output to the DCN. Now, what is DCN? It is deep cerebellal nucleus, right? So, first of all, if we have to remember all the factors, that from the climbing fibers, the input came to the, to the Purkinje cells, and they said that this much flexion for this much time I had to do. Now what happened? One more copy came from the, the mossy fibers, which are coming directly from the, through the granular cells, through the parallel fiber, it also reached the Purkinje cells, right? It also reached to the Purkinje cells. Right, and they told that only 8 degree of flexion occurred. Now, what Purkinje cell did is, it got the input from two areas, from the higher centers also and from the muscles also. So, it corrected the error, and through the DCN, it gave the output to the muscle again, and hence correcting the error. So this is the phenomena of Purkinje cell and their mechanism of working. So hence the cerebellar cells helps into the coordination and posture maintenance, and this is what they showed as a Purkinje cells, right? These are the Purkinje cells. Moving on to the next question, question number 5, water hammer pulse, right? So how it looks like, let's see. So these are the normal pulse and these are the water hammer pulse. So you can see over here that there are a bounding, forceful kind of pulsation you can feel in the physiological conditions also. For example, sometimes in the pregnancy as well as the exercising person, right? So this is nothing but the forceful bounding pulse, right? And over here the pathological conditions are given. So answer over here is is the atrial regurgitation. Now why atrial regurgitation? Let's have a look on, right? So always remember, you can see this pulse will look like this, right? And you can feel the water hammer pulse. If we have to discuss this topic, let's discuss what happened and why this water hammer pulse is having the or it is known as the bounding pulse, right? So first of all, water hammer pulse. It is the forceful bounding pulse with rapid upstroke and descent. So in the diagram you can see that it is having a rapid upstroke as well as descent, right? It should be like this. Normally the second diagram should be there, but in the pathological condition, in some hyperdynamic conditions, this phenomena will take place, right? So as we know that it is having forceful and bounding pulse, and why this occur, there are different reasons for that. For example, as we discussed that pregnancy and the exercise, those are the physiological condition, and pathological condition, there are many pathological conditions also, that is any hyperdynamic circulatory state can cause this. If we have to take the examples, atrial regurgitation, which is already there in the options, right, as well as the thyrotoxicosis, then your anemia, Paget disease, so on and so forth, right? And as well as in the fever, high grade fever, also you can see the water hammer pulse, right? So why they are there? What happened in the atrial regurgitation, especially while filling the heart or filling the water hammer pulse, what actually happen is there is an increase in stroke volume because it is a hyperdynamic condition. So there is an increase in stroke volume. So, and that is filling, this increase stroke volume filling relatively empty arterial vessels, right? So the arterial vessels was empty and the stroke volume, which is in the hyperdynamic condition, which is already increased, it is filling the relatively empty arterial vessels, leading to, this will lead to rapid upstroke. We have to discuss that why there is a rapid upstroke. We already said that there is a rapid upstroke and as well as there is a rapid descent also. So rapid upstroke is because of this, right? As well as if we have to discuss in the atrial regurgitation condition, how we can discuss that, we know that there is a regurgitation, right? So from the aorta, the blood is not going only in the arterial system, but it is coming back to the left ventricle also. So the end diastolic volume is increasing. If I have to write it in the short, there is a increase in the stroke volume secondary to, yes, increase in the EDV, right, due to regurgitation, or you can say retrograde blood flow. Retrograde blood flow from the aorta, right? From the aorta in the diastolic condition also there is a retrograde blood flow. Now what happens is, because of this, the stroke volume will increase, and that's why if there is a stroke volume increased in the stroke volume, again you'll see the rapid upstroke. So that is the funda about the rapid upstroke. Now let's discuss why there is a rapid downstroke. It is due to two conditions. That first is, it is due to decrease in the diastolic blood pressure in aorta, because the blood is, there should be a phenomena of recoil, right? In the systole, what happens is aorta will be stretched. Then in the diastole, as soon as the aortic walls will be closed in the normal condition, what happens in diastolic also, there is a pressure, that is 80 mmHg is maintained because of the recoil of the aorta. But over here it is not happening. Why? Because already the retrograde blood flow is there in the left ventricle. So there is a decrease in diastolic blood pressure because of the regurgitation of the blood. Right. This phenomena is also known as, it is it have a name, that is aortic runoff. So this can be a question that aortic runoff is seen in. So you should remember it is seen in the aortic regurgitation, and that is through the leaky aortic valve. The leaky valve, right? What is the another cause of rapid downstroke is, there is a rapid emptying. There is a rapid emptying of arterial system. There is a rapid emptying from the arterial system too. And why that occur? That occurs because, yes, that occurs because there is a decrease in the stroke volume, decrease in the cardiac output. That occurs because there is a decrease in the stroke volume. That occurs because there is the decrease in the diastolic blood pressure. So whatever blood amount should come in the arterial system, it is not coming in the arterial system, rather it is going back to the left ventricle. So that's why there is a rapid emptying of arterial system too. And also there is decrease in DBP. Why there is a decrease in DBP is, the compensation, now there is a decrease in DBP, we know why, right? And for the compensation, what happen is, there are again two ways of compensation, right? What are those two ways? First of all, the heart will go under the dilatation. There will be chamber dilatation. Chamber dilation, right? Chamber dilatation or dilation, and that is nothing but the eccentric hypertrophy. Eccentric hypertrophy. Why? Because the stroke volume is increasing, EDV is increasing, the heart have to pump with large force, right? So that's why hypertrophy will be there. And the second mechanism is the sympathetic system will be activated, which will release the catecholamine, which will release catecholamine, as well as it will activate the RAS system. RAS system, And this all happens to increase the cardiac output and to maintain the mean arterial pressure. So that is all about the cardiac output, DBP, and what all the condition we can see in relation of water hammer pulse, right? So one of the condition is aortic regurgitation. In the mitral stenosis and aortic stenosis, this phenomena cannot occur because the stroke volume will not be increased, rather it will be decreased because there is some obstruction to the outflow, right? And in the left ventricular failure, the heart is already dilated, right? And there is minimum to negligible outflow, right? So the answer of this question is option A. Moving to the next question, that it is about the inferior frontal gyrus and functional area would mostly affected. So answer of this question is option D, motor speech. And why this is the answer? Let's see a diagram. By that you'll get to know why this is the answer. So this is the diagram I want to show to you, that there are two important areas for the language. That is, first one is the, it is the Broca's area. It is the Broca's area, and another is the Wernicke's area. Now over here you can see Broca's area is area number 44, and the Wernicke's area is area number 22. Now you can see that it is present in the inferior frontal gyrus, right? And the Wernicke's area is present in the superior temporal lobe, right? So what are the function of this area are the superior temporal lobe, the Wernicke's area have a function, that is, it causes the understanding of the word. In simplification, if I have to say, it causes the understanding of words. Whatever you are speaking or whatever I am speaking, you are able to understand what I actually meant by, right? So there is an understanding of the words which are happen due to the Wernicke's area, as well as language, right? Then the speech and writing. So basically this is the for the understanding or integration of the language. If we have to see the functions of Broca's area, what it causes is, it is the area number 44, as we already discussed. It is, first of all, it is the motor area. So if it is the motor area, it should help in the motor functions, right? And it is also helping in the language. So how this both can integrate with each other, that it helps in the motor speech. It helps in the motor speech and as well as the word formation. So that's why these two areas are very much important for the language. Now, in between these two, you can see the fibers which are connecting these two, right? So those are the arcuate fasciculus. Those are the fibers of arcuate fasciculus. Now, what is the function of arcuate fasciculus is, it connects the both areas. Both the areas are connected by arcuate fasciculus. If the lesion of Wernicke area happens, what happens is, there is the sensory or fluent, or you can say senseless aphasia will take place, which is also known as receptive aphasia. Now, why it is known as or it is having these many names? Because it is not the motor area, so it is also known as sensory aphasia, fluent aphasia. the person is not able to understand what the person is talking about, right? But his motor area is intact. The lesion is in the Wernicke's area, the motor area is intact. So he is able to speak, but the word formation, because of lack of understanding, the verb formation will not be appropriate. So that's why it is also known as the senseless aphasia. The person is able to talk, but it will be the senseless speech. So it is also known as senseless aphasia, right? So this is about the Wernicke's lesion. What about if the lesion is in the Broca's area? If the lesion is in the Broca's area, it is also known as the motor aphasia or non-fluent aphasia or expressive aphasia. Now, the Wernicke area is normal, so the patient is having a normal understanding, but his motor area is not able to work properly because the lesion is in the Broca's area, which is the motor area. So the person will not be able to form the words, right, or the motor speech. So that's why the talk will be not fluent, right, and he can we can see that. So it is also known as expressive aphasia or lesion in the motor area, so it is known as motor aphasia too, right. That is about the Wernicke's and the Broca's area. But we do have fibers which are connecting these two areas, that is the arcuate fasciculus. What happens if the lesion in the arcuate fasciculus is there? If the lesion is there, that is known as the conduction aphasia. The conduction aphasia, right? If the lesion is in the arcuate fasciculus, that is known as conduction aphasia. Okay, so what will happen in the conduction aphasia is there will be slow speech. The area is not able to connect properly, so the person's speed of the speech will be decreased, right? There is one more term that is known as global aphasia. Now, what is global aphasia is if the large area have a lesion, that is known as global aphasia, right? So, why this occur? Many a times this question is asked, why the cause of the global aphasia? So, middle cerebral artery, if it is damaged either by the hemorrhage or by the infarct, either by the hemorrhage or by the infarct, the global aphasia, the larger area will be affected, right, and have the lesion or pathology. So that's why these all area will not be able to work. So there will be a global aphasia. So this is about the Wernicke's and their areas and whatever aphasia they are causing. Moving on to the next question about the fibers, nerve fibers, right? So answer over here is option A, that is A fibers, right? Why? Let's see. The patient is having a tingling sensation, and this is because for long hours the hands are under head. So pressure component is there, right? The pressure component is there. So for that, you should know one of the classification of the nerve fiber, that is, yes, Erlanger and Gasser classification. Erlanger and Gasser classification. Now, what this classification says is there is three types of nerve fibers, that is A, B and C, right? A, B and C. Now, the A fibers are thick and myelinated, right? And the B fibers are thin, myelinated again. the C fibers are unmyelinated, right? So, if the myelination is there and these fibers are thick, which is having the maximum diameter, if the diameter is bigger, so it is inversely proportional to the resistance, so resistance will be less, so minimum resistance in the A fiber, that means the velocity or the speed will be maximum, right? And if we are talking about the speed is generally 70 to 120 meters per second. 70 to 120 meter per second, right? This is about the A fibers, right? Let's talk about B fibers. What about the B fiber? They are the myelinated one and they are in between the A fiber and C fiber if we compare the diameter, right? And its speed is 2 to 5 meter per second. 2 to 5 meter per second, right? If we have to talk about the C fibers, that it having a speed, it is the slowest one because the diameter is less as well as it is unmyelinated. So, solitary conduction is not possible in the fiber C. So, the speed is less also. It is 0.5 to 2 meter per second, right? This is about the A, B and C fibers. Now, A fibers are also subdivided into again 4 types. That is A alpha, A beta, A gamma and A delta, right? And they do have different functions, right? We're not going into the functions, but we should know that the A alpha motor neuron and gamma motor neuron, so they are the motor neurons, right? And the beta and the delta, they are the sensory neurons, right? So beta are for general sensation, usually general sensations like pressure, vibration and all, and the delta is for the pain, and which is known as fast pain, right? If there is a fast pain, there must be a slow pain which is carried by the C fibers. Slow fibers. Okay, so we know that A fibers are having the motor and sensory fibers, right? A fibers are the somatic fibers which are having different sets of fiber, that is the motor fiber and the sensory fibers. Motor fibers are alpha and gamma and the sensory fibers are beta and delta, right? So if we have to talk about the pressure factor, if we give the pressure, the fiber which is having the maximum diameter, that going to compress much more earlier, right? So if we have to see the effect on the nerves of the pressure, the A fibers will be affected maximally, then the B, then C. That will be the sequence, right? If we have to talk about the hypoxia, the B fibers will be affected first, then A, then C, right? If we have to talk about the chronexy, the question is asked in the AIMS exam that what is the sequence of chronexy? So, chronexy is the minimum amount of time which is required to show the response. So, remember, it is inversely proportional to the excitability, right? It is inversely proportional to excitability. So, chronexy, if we have to talk about the chronexy, the order should be C fibers, then B fibers and the A fibers, because C fibers will take maximum time, right? So, C fibers will be taking maximum time. So that is about the Langer-Grasser classification and the nerve fibers and related question that can come in the exams, right? So moving on to the next question. Now a person is having an accident and the superior temporal gyrus is affected. We already discussed that in the superior temporal gyrus we do have Wernicke's area, and because of that, yes, the fluent aphasia will be there. Fluent or senseless aphasia or sensory aphasia will be there, which is already discussed in the previous questions, right? So let's move on to the next question. So they ask about the reflex, right, which inhibit the gastric emptying, acid and hypertonic solution is there. Then the answer of this question is option A, enterogastric. Now let's see why the answer of this question is enterogastric and what all the reflexes that we can see in the GIT for this particular topic, right? So remember, always remember, there are two types of reflexes. Intrinsic reflex and extrinsic reflex, right? Intrinsic reflex and extrinsic reflex. What is intrinsic reflex is the whatever reflexes that are occurring through the enteric nervous system, not through the central nervous system, but those are occurring through the enteric nervous system itself. They are known as the intrinsic reflexes, and those who involve the CNS, those are the extrinsic nerve reflexes, right? So then there are three types of extrinsic reflexes that we can see. Those are, first one is enterogastric, second is gastroiliac or gastroileal, right? And third one is gastrocolic. For this particular question, we are going to discuss the first reflex, that is enterogastric reflex. Now, what is the enterogastric reflex? It is very easy reflex. Entero means intestine, gastric means the stomach, right? So it is related to these two. So what happens is, once there is a stretching of duodenal wall, there will be distension, right? There will be distension, and this distension, it will lead to two things. One is the inhibition of gastric motility and decrease in the gastric emptying. Gastric motility and decrease in the gastric emptying. Now, not only by the stretching, but what if there is an increasing acidic content? Then also these two responses is seen. When there is a stretching of the duodenal wall, it understands that something, the chyme, whatever chyme is there in the stomach, that has come into the duodenal wall, right? So that will lead to inhibition of gastric motility and emptying, right? So this is nothing but the enterogastric reflex. It started from the intestinal wall, that is the duodenum, and the response is seen in the stomach, right? So that's why it is known as enterogastric reflex. Enterogastric reflex, right? Now the emptying occurs through two things. One is the parasympathetic system, One is the parasympathetic nervous system, and the second is whether there is an increase of volume, when there is an increase of volume and fluidity of gastric content. Increase volume and fluidity of gastric content, right? So there will be emptying of the stomach, right? And if we are discussing the emptying factors, let's see what are those factors which inhibit the emptying. Now, inhibit the emptying. The factors, those inhibit the gastric emptying. Now, what are those factors which inhibit? We already saw some of the factors, that is duodenal distension, right? Then acidic pH, that is acidity, or duodenal hypertonicity, which is present in the question also, hypertonicity, right? Increase in the osmolarity of gastric chyme, increase in the osmolarity of the gastric chyme, and sympathetic nervous system stimulation, as well as there is the one more thing which causes the inhibition of the emptying, that is intense pain. So the factors through which the emptying occurs, that is the parasympathetic system, and volume and fluidity, increase volume and fluidity of the gastric content, and which factors that decreases the gastric emptying. So that is about the question as well as the enterogastric reflexes, right? So moving on to the next question, that is multiple sclerosis. Now, what happens in the multiple sclerosis is there is a loss of myelin sheath. As we already know, let's discuss some facts about the multiple sclerosis. So what happened in the multiple sclerosis is, this is an autoimmune disease, multiple sclerosis. It is the autoimmune disease, right? It is autoimmune disease. What happens is, and if we have to define it, then you can write it as chronic, progressive. It is not acute. It is a condition which is progressing. So chronic, progressive and degenerative disorder that disrupt the axonal myelins, that and we already know that if the factor is the nerve fibers are myelinated, the conduction will be faster because of this alteratory conduction. Now over here what is happening is the antibodies are attacking on the myelin sheath, and that's why there is a disruption of the axonal myelin sheath, right? So this happens in the CNS. So there is an alteration in the saltatory conduction, right? And if the alteration is there, so there will be decrease in the conduction velocity. So there will be decrease in the conduction velocity in the CNS, right? Because of disruption of the myelin sheath. Now, what are the causes of it is etiology. This is autoimmune disease. The causes are, the risk factors are, it can be genetic or an early exposure of environmental factors, right? Or early exposure of diseases like viruses like Epstein-Barr virus or measles, herpes, chickenpox, herpes, chickenpox. What else? The influenza, right? So these can be the factors. The etiology is unknown, right? These can be the risk factors, right? So what happens is antibodies are attacking the myelin sheath, and that's why there is a inflammation. The inflammation is taking place. Inflammation is taking place and injury to the myelin sheath. Right? So, injury to the myelin sheath. Now, we know that there is a decrease in the conduction speed. Why? Because there is leakage of potassium through voltage gated channels, which will lead to hyperpolarization. And if there is a hyperpolarization, the action potential is produced because of depolarization. If the cell remains in the hyperpolarization state, it is difficult to produce the depolarization, and hence there is a failure to conduction of AP. So this is a simple phenomena. If there is a leakage in the potassium, there will be hyperpolarization and failure in the AP conduction, that is action potential conduction. That's why the speed of that particular nerve will be decreased, which is affected by the multiple sclerosis, right? So answer of this question number 10 is option B, right? Moving on to the next question, respiratory distress syndrome. In this, you should be knowing about the surface tension, the surfactant, why it is causing, and through which the surfactant is released into the cell, alveoli, right? So, answer over here is option B, type 2 alveolar cells. Now, let's see why and how this type 2 alveolar cells help into maintaining the respiration, and what happens if the lesion will be there, right? So for that we should know what is surface tension. What is surface tension? Now, surface tension is nothing but the inward force acting maximum at air fluid interface, right? Now, if I have to show the air fluid interface, suppose this is the alveoli and the alveoli are lined by the layer of water or fluid, right? And inside it, it is connected with the atmosphere through the different airways, right? And the air is there. Now, there is a this thing which I draw in between them. The line is, yes, this is nothing but the interface of air and fluid. This is interface, air fluid interface. Because of this, there is an inward force. So, alveoli try to collapse. Right. So, if there is a surface tension, presence of surface tension, what things can happen? So surface tension, because of the interface, it will try to collapse the alveoli, right? It will try to collapse the alveoli, which is known as atelectasis, and because of this condition, what will happen? It will try to pull the fluid that will not only collapse the lungs or the alveoli, but it also pull the fluid from the pulmonary capillaries. And that's why the pulmonary edema will take place. If the surface tension is there. Now we have to remove this surface tension because we don't want our alveoli to collapse. So that's why this layer is lined with a substance which is known as the surfactant, which breaks this halter the air fluid interface, which is known as surfactant. Now what the surfactant will cause is, first of all, it is released by type 2 pneumocyte, which is the answer of our question, type 2 pneumocyte. Now what this is composed of? It is composed of two things, 70% phospholipid and 30% glycoproteins. Phospholipid and glycoprotein. Now there are many phospholipids are present, but maximally there is one of the phospholipid which is present maximally, that is DPPC. What is DPPC? It is dipalmitoyl. The name already asked in the exam too, that is dipalmitoyl phosphatidylcholine. Dipalmitoyl phosphatidylcholine. And the glycoproteins like fibrin, for example, there are many glycoproteins. I'm giving the example, that is fibrin, or for example mucopolysaccharides, etc. Right? So these are present in this. This is the composition of surfactant basically. Right? Now what is the mechanism through which it decreases the surface tension? It covers the layer of air fluid airflow interface, right? So it covers the water surface, and hence it covers, this surfactant layer covers the water surface, and hence decreasing the surface tension. What if there is an absence of surfactant, or decrease? You may write decrease or absence of surfactant. So there will be increase in the surface tension, and that will lead to the distress in the inspiration as well as expiration. There will be a difficulty in inspiration and expiration, which is known as respiratory distress syndrome, and that is the question of the NEET PG exam. And respiratory distress syndrome, in that the deficient cell will be type 2 because they are releasing the surfactant. Moving on to the next question about the fertilization most commonly take place. It takes place at ampulla, right? So option B will be the answer. Now if I have to show you the diagram of this particular question, we can see that, yes. Now there are this is the uterus. This thing is uterus. Over here isthmus is present. This is the fimbriae, the projection which are coming from the fallopian tube. This hole is the fallopian tube. Over here, what you can see are the fimbriae, right? And between the fimbriae and this region is known as isthmus. Infundibulum. This region near the fimbriae is known as infundibulum. This is known as isthmus. This whole region of 10 centimeters, it is approximately, it is known as ampulla. Ampulla. Right. Now, what is fertilization? If I have to talk about the fertilization, what I can tell you is that fertilization is nothing but the fusion, right? It is nothing but the fusion of ovum and sperm. Sperm, which in turn will form the zygote, which in turn will form the zygote. And most common site that happens is the ampulla. Most common site is the ampulla. Right, over here you can see the sperm is coming and ovum is getting fused. These two are getting fused, which is known as the fertilization, and the most common site is ampulla. Now, how this thing happened? Because the capacitated sperm attracted to the progesterone, which is released by this ovum, right? So, ovum release progesterone. Now, whatever capacitated, that means whatever sperm are come into the uterus of a female, that is capacitated sperm, get attracted to this, get attracted to the progesterone, which is released by the ovum, right? And that's why the sperm will get the direction, right? Now, this progesterone is excessive progesterone is released by the cumulus cell. This question was asked once in the JIPMA that from which cell it is released. It is released by the cumulus cells, right? Cumulus cells, which is surrounding the oocyte. Which is surrounding the oocyte, right? And that will act on this progesterone should act on the sperm, right? And there should be a receptor. So the receptor is cat spur. Cat spur is the receptor which is present on the progesterone receptor, which is present on the sperm. So progesterone is released from the oocyte, from the cells which are known as the cumulus cells, and that will act on the receptor which is present on the sperm, which is the cat spur sperm, right? Now, if this progesterone is acting on that receptor, it is not only showing the direction, but it increases the intracellular calcium levels in the sperm, right? Intracellular calcium levels, and make it hyperactive. So it is giving the hyperactive motility, providing the motility functions also. So increase in the calcium levels, and that will lead to hyperactive motility. So that's how the fertilization take place once the sperms are capacitated, right? The most common site, as we all know, that it is ampulla. Moving on to the next question, that the blood stores into CPD, right, is better for the hypoxic rather than acid citrate. Now the acid word is important, right? The answer of this question is they fall in the 2-3 BPJ. Let's see why, how, right? So if I have to discuss about this topic is, let's discuss. Now, we know that if the solution is acidic, that will inhibit the DPG mutase enzyme. DPG mutase enzyme, which will lead to decrease in 2,3-DPG. The BPG and DPG are one of the same things, right? D for di, B for bi. One of nothing but the same things. So 2,3-DPG say or BPG, nothing but the same things. So the formation of 2,3-DPG will decrease. Once this formation is decreased, that will lead to, yes, this in turns will lead to left shift of oxygen hemoglobin dissociation curve. Oxygen hemoglobin dissociation curve, and hence reducing the oxygen delivery in the tissues, right, in the tissues. Now already the patient is hypoxic. If you give this acidic solution or HD, what will happen? There will be that acidic solution will inhibit the DPG mutase enzyme, which will lead to decrease in the formation of the 2,3-DPG. Then it will cause the left shift and decrease in the oxygen delivery, hence deteriorating the patient's condition even more. So ACD is not preferred in hypoxic patient, right? That is acid citrate dextrose is not preferred in the, yes, what thing? The patients of hypoxia, right? Okay. If we have to discuss about so answer of this question is option C, right? Moving on to the next question. Question number 14, right? It is talking about the paresthesia. It is showing that the patient is anemic, as well as on the peripheral smear we can see the macrocytes, right? So macrocytic anemia is there, and the neutrophils are hypersegmented, right? With that, the patient is also having atopic gastritis, right? So this is nothing but the typical case of vitamin B12 deficiency. It is a typical case of vitamin B12 deficiency. If we have to know why, before that I want to share the factors those affect the curve, right? About the oxygen hemoglobin dissociation curve, the left shift is because of decrease in PCO2, decrease in the H plus ion, that means increase in the pH, remember that, right? Increase in the pH, decrease in the 2,3-BPG as we already discussed, which was the important point for the question, right? Decrease in the temperature and the HbF, that will cause the left shift, and the right shift is reverse of that, right? Hypercapnia, decrease in the pH, increase in the 2,3-BPG, and increase in the temperature, that is hypothermia, will cause the right shift. About the question number 14, this is the formation of vitamin B12. Once into the salivary glands, the cobalamin, right, is coming over here. Cobalamin is coming over here. So moving on to the next question, let's see what is the next question. So as we know, for the question, the answer is yes, option C, right? The question number 13, the answer is option C. Let's move on to the next question. Now over here, the 50-year man having anemia which is macrocytic. Remember macrocytic, the neutrophil is showing hypersegmented nuclei, right? And with that, the patient is also having atrophic gastritis. So answer over here, it is a typical presentation of vitamin B12 deficiency, right? Vitamin B12 deficiency. If I have to discuss about this, let's discuss why and how the answer is vitamin B12 deficiency. Now, vitamin B12 deficiency can be because of the autoimmune disease, right? So, vitamin B12 deficiency. Over here in this deficiency, what we can see is there is a marked pancytopenia. Marked pancytopenia. Right? And it is characterized by what thing? There is a decrease in hemoglobin level, which is already there in the question, right? And as well as decrease in WBC and platelet count. Decrease in the WBC and platelet count. If WBCs are decreased, right, what will happen to the neutrophil? Neutrophil is one of the type of WBC, right? That means the newly generated neutrophil will be less and the older neutrophils will be there, and which is the presentation, that is hyper segmented nuclei of the neutrophils are seen, right? Now on the peripheral smear, what we get is there is a oval macrocytosis, and hyper segmented neutrophils. Right, hypersegmented neutrophils, and that is the typical presentation with the macrocytic anemia. Right? Now B12 is involved in why there is an atrophic gastritis. Let's discuss that. B12 is also involved in, yes, what thing? DNA synthesis. It is also involved in DNA synthesis, right? If it is involved in DNA synthesis, what happens if the deficiency is there? If the deficiency is there, abnormal cell growth and development will be there. Abnormal cell growth and development, or rather you can say maturation. Cell growth, development or maturation will be there, right? Now, because of this, what happens is there is abnormal epithelialization. And we already said if it is because of the autoimmune disease, which is the typical case of B12 deficiency, in autoimmune disease they also damage the antibodies, they damage the gastric mucosa, they damage the gastric mucosa. Damage gastric mucosa, right? And that's why we see atrophic gastritis. Atrophic gastritis. Remember, For B12, some points are very important about its absorption and synthesis also, that we will discuss. But for now, remember that this absorption of B12 that occur in terminal ileum, and for that we do Schilling test. For B12 we do Schilling test. What are the complications? If we are discussing the case of B12 deficiencies, let's see what is the clinical significance. You can see subacute combined degeneration of spinal cord plus peripheral neuropathy. Glossitis and annular stomatitis. So these can be the presentation of that patient. So that is all about the B12 and some related questions on B12 deficiency, right? Moving on to the next question about the JVP. JVP is jugular venous pressure. It is due to, in the C wave, a C wave. It is due to the bulging of tricuspid valve during the isometric contraction. So what are the different waves in the JVP and what are the causes of that particular wave, right? So let's see a diagram for that. So this is a particular diagram for the JVP. We have A wave, C wave, X descent and Y descent plus the V wave. So the three positive waves are the A, C and V, right? And two descents are there, which is X and Y. If we have to discuss why they are there, A is because of atrial contraction. A is because of atrial contraction. Now again, the C wave is because of bulging of tricuspid valve, with ventricular contraction, and which is nothing but the isovolumetric contraction, right? Isovolumetric contraction is there with the C wave. Moving on to the next descent, rather X descent, because it is coming down, so it is known as X descent. So descent, downward movement of the tricuspid valve. Downward movement of the tricuspid valve, which is due to atrial relaxation. Then the V wave is because of passive atrial filling. There are two types of filling, passive and active, right? And the V wave is because of passive atrial filling. Then the Y descent. Coming on to the Y descent, it is because of atrial emptying with opening of tricuspid valve. So A is because of atrial contraction, C is because of that tricuspid valve which will bulge, and that's why you'll see a positive wave, right? Then the X descend because the tricuspid valve moved downward and there is an opening of that valve, and there is a ventricular filling is starting. Okay. Then the V wave is because of the passive atrial filling, and Y is because of the atrial emptying and opening of the tricuspid valve again, right? So that is because that is all about the JVP, right? That is all about the JVP. So we already know that the C wave is because of the bulging of the tricuspid valve during the isovolumetric contraction, right? Okay, so moving on to the next question. Okay, next question, they gave the value of pH, bicarb and PCO2, and we have to know what is the case in this scenario, right? So answer over here, I'll tell you, is C, right? It is acidosis. Why? The bicarbs level are low, right? And you know that bicarb is a best buffer, right? So let's discuss not only that thing, the pH is also slightly reduced. We know normal pH is 7.35 to 7.45, right? Over here the pH is 7.2, so it is acidosis. And why it is metabolic acidosis? Let's see that thing, right? So yes, if we have to discuss that, we do have a chart for that. Now you can see, first of all, you should know the normal values of particular substance, right, or particular thing. For that, the pH we already know, 7.35 to 7.45. The PCO2 is 35 to 45 mmHg. The bicarb is normally 22 to 26. In our case, it is 30, right? It is 10. The PCO2 is 30, right? So if the respiratory acidosis is there, you will see it is acidosis. So in the acidosis, remember, the PCO2 will be increased, and in case of metabolic acidosis, you can see that the bicarb is decreased. Bicarb is the buffer, right? So pH, first of all, you have to see the pH. pH, if it is decreased, that means it is more acidic, that means acidosis is there. If the pH is increased, the alkalosis is there. So in the acidosis, you can see that the pH is decreased, and in the alkalosis, you can see the pH is increased, right? Now you have to decide that it is metabolic or yes, respiratory. If the PCO2 values are increased, that must be the respiratory acidosis, right? Because the PCO2 is nothing but the giving the respiratory acidosis value. In the alkalosis, the reverse will happen. In the metabolic cases, the more influence will be on the bicarb, not on the PCO2, right? But in the case, this is in case of uncompensated. In the compensated, both will be affected, the respiratory parameters also and the metabolic parameters also. So common causes, some of the common causes are given over here. If you want to remember those, you have to remember in the case of metabolic acidosis, diabetes, DK is the one of the important and most common cause, diabetic ketoacidosis, and the question is already asked on this, right? Okay, so in our question we can see that the bicarb level is decreased and the pH is also decreased. So it is matching with the metabolic acidosis. Now the PCO2 values are also a bit decreased. That is because now the patient's system is trying to compensate with the acidosis, right? So that's why with the compensation it is trying to get rid of the acid that is present in the respiratory system, that is PCO2, right? So it is the case of compensated metabolic acidosis, right? So that's why the PCO2 levels are also less, but there is no confusion. You have to compare, right? That first of all it is the bicarb or the PCO2 values, right? So this is the definitely case of metabolic acidosis. Moving on to the next condition. Okay, that in this question you have to give the importance to the premature aging Werner syndrome. Now they ask about the mechanism. So aging is related to the telomerase, right? So the answer is short telomerase with the damaged DNA and loss of helicase. Now what happened in this condition is the Werner syndrome is also known as, yes, the progeria. It is also known as progeria. Let's discuss few points because it is already asked question. So the chances are more that it can be repeated, right? So we should discuss the Werner syndrome. It is also known as progeria. It is also known as progeria, and it is autosomal recessive disease. The defect or the mutation is in the chromosome number 8, right? And it is characterized by appearance of, as we already know, yes, premature aging. Appearance of premature aging, right? So what happens in this is there is a short telomerase with damaged DNA. We already know this. Plus with this there is a loss of helicase because of DNA methylation. What happens in this case is DNA undergo methylation, right? So DNA methylation will cause the shortening of telomerase and damage of DNA, right? So what are the symptoms that you can see and how you will identify that this is the condition of Werner syndrome is a premature aging. We already know premature graying of hairs, or also you can see hair loss, severe hair loss or extreme hair loss, right? Bilateral cataract in the early ages, right? Bilateral cataract, soft tissue calcification, sharp facial features. The facial features will be sharp, there will be wrinkling on the face, premature wrinkling, right? And abnormal high pitched voice, short stature due to absence of growth spurt. Remember, the growth spurt in this condition is absent, right? Though there is a shortening of telomerase, quickening of the aging process, but there is an absence of growth spurt as well as there is atrophy of gonads. So pathetic condition, and this is because of the mutation in the chromosome number 8, and it is the autosomal recessive disease. So this is all about the Werner syndrome that you should know of, right? So even if they give the image, you should know, right, with this feature and the symptoms that it shows, it should be remembered, right? Moving on to the next question, question number 18. Again, now the blood glucose is very much high and the pH is low. Now we know that it is the case of acidosis, and we already discussed about the metabolic acidosis and about the causes, that one of the cause was the diabetes. So it is a typical case of DKA, and that's why the answer of this question is option C, right? Option C is the answer. Now, if we have to discuss about this, what we can discuss is the decay condition. Many questions are already asked in the exams, and there are chances that decay is the most important topic in the syllabus. So examiners are very fond of this. So let's discuss something about decay. So this is a typical case of decay, metabolic acidosis. What happened in the diabetes? We already know there is an insulin deficiency. Right? Insulin deficiency will lead to body to metabolize, either it is insulin deficiency or receptors, abnormal receptors, right? Abnormal receptor. The body start to metabolize the triglycerides and the amino acids. Because of lacking of the glucose and energy, it start to metabolize the triglyceride and amino acid. Now what it will lead to? That will lead to increase in glycerol levels and free fatty acid. Glycerol levels and free fatty acid levels, right? Once they are increased, now this free fatty acids will convert into ketone bodies, as we already know from the biochemistry that it will convert into ketone bodies, right? And this ketone bodies production, which is ketogenesis, will lead to metabolic acidosis, and that's how the process of metabolic acidosis will take place in the decay. Some important factor to remember about the decay is there is one more thing, that is osmotic diuresis. Whatever the glucose molecules are there, they are osmotic, so they will take the water, and the more excretion of water is seen, which will lead to, yes, marked urinary losses of the water and electrolyte, right? So this is all about the question about the DKA, right? Decay and its features, right? So moving on to the next question. Okay, so moving on to the next question. Okay, 19. Question number 19. Proteoglycan present in the glomerular basement membrane. Basically, they show the heparin sulfate. Now, why it will show the heparin sulfate is okay. Now, we should know that the glomerular basement membrane having the three layers, that is, it is trilaminar, lamina interna, lamina densa, and lamina externa, right? Lamina densa, lamina interna, and lamina externa are the three layers. This will present next to podocytes. We are only talking about the basement membrane, right? And you should know that the heparin sulfate is the proteoglycan. This is type of proteoglycan which is most abundant class of basement membrane. Which is most abundant class of basement membrane. Now, what is the benefit of having on this on the basement membrane is the negative charges of heparin sulfate, they confer a net negative surface charge on the basement membrane or to the basement membrane. Now, because of this negative charge, what happen is the proteins, they get repelled. And that's why they prevent the proteinuria. And that's why they prevent the proteinuria. So, that is the contribution of heparin sulfate to the filtration, right. So, they can prevent the proteinuria, right. Okay. So, moving on to the next question. This is all about the heparin sulfate, right. Okay. So, question number 19, the answer is option C, right. Okay. Moving on to the next question, the NECP ATP3. Now, what is this NECP is? National Cholesterol Education Program, and ATP is Adult Treatment Panel 3, right. This is just a classification, right, and after looking at the chart, you will get to know what is that classification, and the answer of this question is option B, high LDL, high LDL, right. So, let us see that chart. Okay, over here you can see that 5 things are given, 1, 2, 3, 4 and 5. Abdominal obesity, right. Now, I am not going to read everything, but it is different for the men and women, right. Triglyceride levels, which is more than 150 milligram per deciliter, HDL, blood pressure and fasting glucose. These are the 5 risk factors and their criteria are given. If 3 out of 5, any 3 out of 5 are present, that means that patient is suffering from metabolic syndrome. But 3 out of these 5 criteria should be matched with that particular patient's symptom, right. So, 3 out of 5 symptoms should be there, right. Then only it is known as metabolic syndrome. For that, abdominal obesity, triglyceride, HDL, blood pressure and fasting glucose are the important factors, right. Over here we say that triglyceride, obesity and increase in the blood pressure, right, but LDL was not there, LDL was not in the criteria, rather HDL cholesterol was there, right. So, the answer of this question is yes, the answer of this question is B, LDL, right. Okay, moving to the next question about the VQ ratio, right. If we have to know about the VQ ratio, infinity means it is the dead space, it is the dead space. Now, why it is the dead space? Let's see why it is dead space. If we have to discuss about the dead space, what is VQ ratio? First of all, it is ventilation, perfusion ratio, ventilation, perfusion ratio, right. Ventilation, perfusion ratio. Now, if the ventilation ratio, perfusion ratio, what do you mean by V and what do you mean by Q, right. The V is air coming, air coming air coming to air coming for exchange, air coming for exchange to the alveoli, air coming for exchange to the alveoli, and blood coming for exchange from the capillaries to the capillaries, right? So that is about the V and Q, that is mean by V and Q. Ideally it should be 1, ideally it should be 1, right? If ideally it should be 1, ideally it should be 1, the best, that means it is the best exchange, that means it is best exchange. If it is more than 1 or less than 1, it is known as VQ mismatch, VQ mismatch, right? It is known as VQ mismatch. Now let's see what are the condition in which we can see these two type of VQ mismatch, right? So if it is high VQ mismatch, that means the ratio is more than 1. If it is low VQ mismatch, that means the ratio is less than 1. If it is high than more than 1, that means there is a poor perfusion, right? Poor perfusion. And if it is less than 1, that means it is poor ventilation. Poor ventilation, that means poor gas exchange. If poor gas exchange, that means if we have to give the best example of this, this is hypoxia. Hypoxic hypoxia is the best example for this condition. Now if we say that, suppose if there is almost zero perfusion, almost zero perfusion, right, what will happen to the ratio? 1 to the upon 0, that is in the answer should be infinite. So that means there is no gas exchange, no gas exchange, right? Poor exchange, poor oxygen diffusion to the blood. That means if it is 0, not only poor, but it is, if it is 0, then there is no gas exchange, and that what is required for knowing the answer of the question, right? So in the dead space there is an infinity VQ ratio, right? So there is no exchange, right, because there is no blood vessels present, right? Okay, so answer of this question is option A. Moving on to the next question, in preterm babies respiratory distress syndrome, we already discussed about this, that it should be DPPC, that is dipalmitoyl phosphatidyl choline, due to surfactant and increase in the surface tension, lack of surfactant, increase in the surface tension. Moving to the question number 23, they ask about the tyrosine kinase receptor. The answer over here is the insulin. Let's see why is the answer is insulin. Now remember, there are two types of hormone. If we have to divide it, group 1 and group 2, right? Let's divide this, group 1 and group 2. First of all, lipid soluble substances or hormones, soluble and water soluble. Lipid soluble and water soluble, right? The lipid soluble, they don't have any problem to cross the cell membrane, so they easily cross the cell membrane, right? And they act directly inside the cell. Act directly inside the cell. For example, thyroid and steroid hormones. Thyroid and steroid hormones. Thyroid and steroid hormones, right? So differently they act on different receptors, either on the nuclear receptors or the cytoplasmic receptor. Now, what about the water soluble substances? They cannot cross the cell membrane. They cannot cross the cell membrane. Now what happens? Why? Because they are examples, if we have to give, polypeptides. Best example are polypeptide and also the monoamine like dopamine, right? Monoamines, right? So let's discuss polypeptide, right? Polypeptide. Tyrosine kinase, they will act through either through tyrosine kinase or through GPCR proteins. To remember the tyrosine kinase, we have a mnemonic, that is PIG. P for prolactin, I for insulin, and G for growth hormone and growth factors. So only 3 factors are acting through the tyrosine kinase, that is the prolactin, insulin and growth hormone or the growth factors. For example, VEGF, platelet growth factor, nerve growth factor, vessel endothelial growth factor, fibroblast growth factor, all the growth factors are acting through the tyrosine kinase. All except PIG, which are water soluble, they will act through the GPCR protein. That is a simple formula. First of all, decide that either it is the lipid soluble substance or water soluble. If it is lipid soluble, it will act through either through the nuclear receptors or the cytoplasmic receptor. If it is water soluble, divide it into 2, that is tyrosine kinase or GPCR, right? If it is PIG, that means prolactin, insulin or growth hormone or growth factors, that will act through the tyrosine kinase. And if it is not a PIG hormone and it is a water soluble substance, polypeptide, that will definitely act through the GPCR system with the help of secondary messengers, right? So answer over here is insulin, right? Moving to the next question, that is about the serum prolactin levels are highest in. Remember, it is highest after 24 hours of parturition. Now let's have some discussion on this, that why after parturition these levels are high, right? What happened after parturition is placenta will come out, of the body of the mother, right? Now, because of the placenta coming out, there is a rapid drastic decrease in the estrogen and progesterone. Right? So, and with that there is an increase in the prolactin levels, which is the signal for milk production and increase in oxytocin levels also. When there is an increase in prolactin, there is an increase in oxytocin. Why and how? What is the stimulus for that is, it is because of suckling action of the baby. Action there is a release of oxytocin which help in the milk ejection, right? Milk ejection, and this prolactin will cause this surge in the milk levels. So prolactin, P for P, help in the milk production, and oxytocin helps in the ejection. Remember these two things, that prolactin helping in the milk production and oxytocin helps it in the ejection phase, right? Okay, so answer over here is option B. Remember, in the REM sleep you are not under the stress condition, so the prolactin levels have no interference in the REM sleep. After running and estrogen levels are high, if the estrogen levels are high, prolactin will be low, not high, right? And in the running and REM sleep you don't have any significance of the prolactin. About the next question, they ask about the cortisol levels. Now remember, there is a diurnal system of the cortisol release, right? If we have to see that what is the diurnal system, that the diurnal system is nothing but the cortisol release, right? Di means 2. 2 times we can see the highest peak, that is in the morning 6 to 8 am, right? This is 6 to 8 am, and in the evening around 6 pm, right? So you can remember 6 and 6, 6 am and 6 pm, right? So what actually happened over here is, yes, now they ask about the highest level. So you can say that it is in the normal person after awakening in the morning, right? Approximately 6 to 8 am, right? Why not the other two causes? Why this is the cause? Because in the Addison disease, what happens in the Addison disease is there is a deficiency of mineralocorticoid. Mineralocorticoid, which is the aldosterone. Right? So there is a deficiency of one of the cortisol, right? That is mineralocorticoid deficiency is there, right? So it cannot be the highest cause of highest cortisol, right? And in the normal person, after giving dextromethasone, there is a negative feedback. The person is normal, right? And we gave the dextromethasone. So what happens is there is negative feedback mechanism activation. And through the negative feedback mechanism, we have to maintain the level of cortisol in the body. We already gave the exogenous cortisol, so that's why the endogenous cortisol levels will decrease. So decrease in the endogenous cortisol. So hence the answer over here is the option C, right? Option C. Moving to the next question, that is impaired function of aquaporin results in. Now over here in this scenario it should be the answer is option A, nephrogenic diabetes insipidus. Nephrogenic diabetes insipidus. If we have to discuss over here, we already know that ADH have 2 receptors. The aquaporin, regarding the aquaporin, what I have to discuss is ADH have 2 receptors, right? Which are those 2 receptors? One is the V1 receptor and V2 receptors, right? Now what happens about the V2 receptors? V1 is for GFR regulation. We are not talking about that right now. V2 receptors, what it causes is, once the V2 receptors are activated, they are present on the P cells of collecting duct, P cells of collecting duct. Once they are stimulated, the cyclic AMP, they will act through the cyclic AMP. There is an increase in cyclic AMP. What happened is, there is increase in aquaporin 2 levels. Increase in aquaporin 2 levels, and aquaporin 2, aqua means water. So name itself suggests that that will increase the water reabsorption. They will increase the water reabsorption, right? So with the aquaporin 2, we are increasing the water reabsorption. Now they asked about the impaired function. If the function of aquaporin 2 is impaired, what will happen is, okay, so if we said that increase in aquaporin 2 channels, increase in water reabsorption. So if these channels are not functioning, right, there will be decrease in water reabsorption. That means increase in water loss from the body and through the kidneys, right? And that's what happens in the case of diabetes insipidus, and the cause is in the kidney, right, because the aquaporin channels are in the kidney. So it is diabetes insipidus, that is nephrogenic, right, nephrogenic diabetes insipidus. They gave some another conditions like Liddle syndrome. What is Liddle syndrome? Let's discuss quickly. Liddle syndrome is the autosomal dominant condition. What happens in this is, there is a dysregulation. There is the dysregulation of ENaC channels. ENaC channels. So what happens is, there is a gain in the functions. That means the channel will be hyperactive. So there will be excessive absorption of sodium, and hence excessive with the sodium. If the sodium is getting absorbed, obviously water will follow it. So excessive water absorption. So this is the condition, and that is not related to the aquaporin 2 channels, right? Then they give about the cystic fibrosis. Few words about cystic fibrosis. Now there is a specific gene which is defected in the cystic fibrosis, that is mutation in the gene, that is which is for the gene for cystic fibrosis transmembrane conductance regulator protein. Regulator protein, which is known as in short CFTR protein, right? Cystic fibrosis transmembrane conductance regulator protein. So if the mutation is this in this protein, what happens is, this on the kidney it have an effect. Various organs are affected by this, mainly the pancreas and respiratory system. In the kidney, it may lead to chronic kidney disease, and it have no relationship with the aquaporin 2, right? Next condition was the Bartter syndrome. Now what is this syndrome now? It is a autosomal recessive condition characterized by, yes, it is characterized by decrease in the potassium, or can say decrease in the potassium, decrease in the chloride, and metabolic alkalosis. Now why this happening? Because there is a mutation of NA sodium potassium 2 chloride channels, right? Sodium potassium 2 chloride channel. Now this is a loss of function defect, loss of function defect. So there will be loss of the potassium and chloride, and metabolic alkalosis is seen. Metabolic alkalosis is seen. Urinary losses of sodium also, so hyponatremia is also seen in this case, but it is not at all relevant to the related to the aquaporin 2 channels. So that's why the answer of this question over here is nephrogenic diabetes insipidus. Moving on to the next question, vitamin B12 is found in. Remember, vitamin B12 is found in the animal products. It is found in the animal products as well as milk products, eggs, meat, poultry substances, and fish, right? So remember, this is not present in the vegetarian diet, so vegetarian people are suffering from the B12 deficiency also, right? Because of this they are suffering from the B12 deficiency, right? Okay, so we do have a diagram for that. So over here you can see what are the sources of this vitamin B12. Fish, liver of a beef, then the crab, soya products, cereals, meat, milk and milk product, that is cheese and eggs, are the sources of this condition, right? Vitamin B12, right? Okay, moving to the last question for the day, that is the person had an accident, right? The jejunum is removed, resected, right, and with the ileum, that too with the ileum. In this condition, just concentrate on the part of the ileum, right? The patient will suffer from, he will suffer from the vitamin B12 deficiency. Why? Let's see. So for that you should know the mechanism through which the B12 is absorbed and come in the blood circulation. Now this is the system, suppose this is the system, B12 is coming inside. Now there is a protein which is known as heptocorin, which is also known as transcobalamin or cobalamin, transcobalamin or the cobalamin. Now what is the function of this transcobalamin or cobalamin is it protect, so it is the protection of acid sensitive substance which is the B12. So it protects acid sensitive B12 while it is going through the stomach. So this transcobalamin will protect the B12 while it is going through the stomach. Now it is attached over here, you can see that B12 is attached to the the heptocorin. Now what happens over here is it will move to the duodenum. This B12 will move with the heptocorin to the duodenum, right? Meanwhile the parietal cells will release the HCl and intrinsic factor, right? Now what this HCl and intrinsic factor will cause, the HCl, with the HCl the pepsinogen is converted into the pepsin, right? So pepsin will remove this heptocorin from the B12. It separates the B12 from the heptocorin, whom the pepsin, right? The pepsin will separate the heptocorrin from the B12. Now, the intrinsic factors which is released from the parietal cell in the stomach, it will also go to the duodenum and it will bind to the B12. It will bind to the B12, right? And this will go to the terminal ileum, and it will be, the B12 will be absorbed in the terminal ileum. The terminal ileum, in the terminal ileum, the B12 will be absorbed and the intrinsic factor will go forward, right? So, over here you can see that B12 and intrinsic factors are combined. Over here in the terminal ileum, the B12 will be absorbed, and that's how it is absorbed in the blood, and through the blood it will go and stored in the liver. Remember, the B12 can be stored up to years. B12 can be stored up to the years, not in the days, not in the months. If you are eating properly, the B12, it can be stored up to years, right? 1 to 2 years. Okay, so in the question we can see that the patient is suffering from the it suffered from the accident and had an injury to the ileum as well as jejunum, right? So, he will suffer from the B12 deficiency, right? Gastric ulcer cannot be the case because there is no injury to the stomach or anything else, right? Buffering system is properly going on, so and the constipation cannot be the issue, right? So, answer over here is option A. So, that is all for the NEET 2020, right? That is all. Thank you.